Mga ito mission sa completed. Crystal Mirage completed. Wala akong makita. Completed. Flying Fortress completed. Completed na yun. Wicked Arbor. Numbers of Poise. Ano mo ah?
Wala nga.
Ash. Create room.
Job trees.
Ano? Sage.
Monk Affinity.
Increase magic.
Ano? Good.
Nana, gibit ta ka.
Lang, ngisap ko.
Increase magic.
Good.
Yung dismantle ko. Gano'n ako 31 anima share. Wala din ako na-save to last time.
Ito pag dismantle.
Punta ko sa Smith ka ng marag start. Pag man marag naman sa Picas.
Oh. Pangaro mo sa ko kay ready room setting.
Hindi, mato ka sa start. I-click mo ang options. Kano ka ng marag na balay. Cornelia.
Smithy. Tapos dismantle. Saan pag dismantle sa kuhan?
Okay, select all naman ako. Itang tao naman niya wala mo ginagamit. Decrease action ability cost. Decrease action ability MP cost.
Oh, ano select?
Triangle. Square. Puman select all.
Si mo dismantle niya pati akong disugo.
Di man. Wala yun.
Pa-check mo good.
Gani, pero maano man niya.
Hindi na ako mag-dismantle. Muna to.
Nya ang imong ano?
Tama din.
Nga pa kumanin ba? Narang di mo nag-email dira sa player.
Kaya na.
Jadi na? The Wicked Arbor 15 16.
I think I know this place.
Careful, or you'll upset Jack.
There's a reason we can't remember our past.
Like what?
So we can focus on our mission. What else?
All right. I can get behind that theory.
Let's go.
More trash to dispose of.
Away with you!
Nalaganisa na to kakauban.
Time to fly! Let's get ourselves together.
Nalaganisa.
Nuisance.
Let's knock them down.
Better try something different. Go to the light.
Exploit that weakness, Jack!
Finishes it.
Here. I'm done with you. Feel the pain.
Alright.
Keep your wits about you and we'll be fine.
We're a few steps behind.
Don't worry. We got this. Pick a side!
Let's be quick.
Jack, let's go.
Hindi ko kayo babasa, kanila ko gano'n ito.
Come on!
Sa wala.
Pilit sila sa bato kay sa wall, ano sila.
I'm ready.
Wala ilang RB. Kailangan sila maisip sa bato.
Away with you!
Time to fly.
I'm done with you! You're dust!
Boom. Dragon ha.
Pero sakto.
Just in case.
Ano?
This water is so clear. Let's try some.
Ano, kabayo? Kalaban?
Nice.
Okay.
Not dead yet!
Jack, watch yourself.
Tadyakan ko.
Go to the light!
Mukhang kabayo.
This might be worth using.
Nice. There you are.
I expect to be impressed.
Here!
Time to fly.
I'm done with you! Away with you!
Wow.
Go to the light! Away with
Kanina sa likod.
Hello? Yung K-mobs ako. Yung club.
There you go!
We're safe. For now.
I could keep going.
We should be fine here.
So, what now?
Up ahead.
You
That
are
thing's
mine.
huge. Must be good soil.
It's still in our way. Let's cut through.
Jack, look at that. Bet you can't break that wall. Time to fly.
Nice try!
We've faced much worse.
Barely even worth the trouble.
Oh, are those cubes?
Let's have a look.
Tama to ni sa kauban na to. Sofia, ano ko ba nito na si Sofia? Sofia dito.
Kaya ito babae.
Hindi. Job trees.
Pajilis.
Unlock.
I can barely see a thing in this fog. We had better proceed with caution.
Mana?
Go to the light!
Parang alternate.
Away with you! I'm done with you! Found your weakness.
Ah, trapa.
Go to the light. Done with you. Got you now. Die already. Keep it together. There. Nice try. It isn't over. Time to die. There you go. Away with you.
Good.
Gawa na kumana.
Grabe, power ka boy.
Your time's up. Die already. Feel the pain.
Kailangan robot.
Pero ba tingin ka na rin sa video? Nadrop? Dito.
Mulburo. Mulburo boy.
Away with you.
Careful of its breath. I don't even want to imagine what it'll do to us.
Indeed. I can barely stand to look at it. Let's be rid of it.
Go to the light.
Bye-bye.
I'm done with you. It's look better. Move aside.
Getting sloppy.
We need to patch ourselves up. Keep it together.
Tinigil-hulugan ako.
Gotta love shortcuts.
For the next time, we need a breather.
So tell me, which one will you choose?
Which what?
Reward for restoring the crystals. Will it be treasure or the princess?
I don't remember being offered a reward.
Of course you were. You just forgot.
Poor Sarah. Being offered up like a prize. If I were her, I'd be pissed.
Me too. But ridding the world of royalty's old-fashioned ways is no easy feat.
Well, maybe the Warriors of Light can do something about that.
Out with the old, huh?
You can't choose.
Me either. One hand, you'd get the crown. But it ain't like.
At least you'd be rich.
All right, that's enough childish daydreams out of you two.
Yeah, grow up.
This one's got some teeth.
Think before you strike.
Blunt.
I barely even got going.
Next.
A warm welcome.
Come on, follow me. There you go.
pala eh. Nulong.
Keep it together. Now then,
Let's get ourselves together.
let's go.
Let's knock them down. There you are.
Hindi, kailangan hindi ka
Let's
tatanggol.
go. We should be fine here.
I could keep going.
Hindi, good. Hindi mo nahulo. Ay,
Go to the light. All right,
sa pikas mo good na dapat.
this is the one.
We should be fine here.
I could keep going.
Wala, ganun din. Ano ito?
May sunog ko na.
Kasi mali ang atong gagya. Doon ako itong babae nga na ikon. Paano ako mahulog talaga dapat katong green ko.
Up ahead.
Time to go to work. Away with you! Out of my sight! Go to the light!
There's a curse on your head. We'll be sitting ducks like this.
Yeah, yun po yung box.
Back off!
Yeah.
Dito.
I'm done with you! Got you now!
Kasi kalaban naman si Ifrit dito.
Here!
Look around them.
So, that's the volcano, huh?
Sure looks like it. I wonder if we'll run into another fiend.
Warm welcome.
Time to go to work. Nice try!
Oh, ano gana?
Open na siya.
Naka ng gidog mo.
Yun sa mo?
So bago naman to.
Sure as
Pero sa
human.
pikas na siya katong naiasa itong
Must be
mga
all this
flower.
ivy.
Dito na siya bubog.
Now then.
Try not to get hit.
Okay. Come on!
Okay, sige to.
Time to fly.
Let's see what's inside.
May box through. No.
Eh, ano ba ko yung light?
There you go. Let's knock him down.
That was quick.
Keep it up, everyone.
Feel the pain!
Warm welcome.
Come on, follow me. Here. I'm ready. Start with you. Move aside.
Up ahead.
Come on, follow me. Go to the light. I'm done with you.
Guys, kung patay tanong sa taas, mag-brain na.
Hindi, pwede ko yung mana.
Kano, ng violets. Agad.
Yung mana sa mga nabagsaka. Si Bander. Ito. Balls.
Stinks.
Tell me about it. This is never gonna wash off.
Get ready.
Boom. Okay ng ano, Marlboro.
This one must be the tyrant of the forest. It's disgusting. I want it out of my sight.
What's it doing to the ground?
Go to the light. There you go.
Yeah,
Damn it! It's attacking from beneath!
This one's got some teeth.
We gotta keep our heads cool.
Okay. I'm done with you.
Damn it! It's attacking from beneath!
Oh god.
Damn it! It's attacking from beneath!
Keep it together. Okay.
Damn it! It's attacking from beneath!
Alright.
There you go.
Wag.
To be honest, I think it's kind of cute.
We'll have to agree to disagree on that count.
I'm ready.
As if it wasn't revolting enough. Watching it regrow makes my stomach churn.
Here. You've looked better.
Can you feel your legs?
Silence.
We'll be sitting ducks like this. There you go. There's a curse on your head.
Okay. Ah! Wag.
Recall ko rin. Pang.
It isn't over. Come on! Damn it! Almost out of potions.
Gotta stay sharp, guys.
Ganyan na siya.
I'll annihilate you!
So...
Very good numbers.
Tapos nilevel up akong sword, so nalaman ako siya gamit.
Hatag siya sa ano.
Jack, your crystal!
Ang ganda na po ni Ronogun.
Your memories will be stored in this device. Be sure to bring it back.
Hurry, Jack!
You okay, Jack? You were checked out for a bit.
The smell got to my head. So that mist comes from the darkness.
That's right. Its power is frightening. It drives man and beast alike to madness.
Fire.
Warlord. Red Mage. Job trees. Meteos. Job trees.
Ready na.
Increase magic damage dealt. Ready na, ma? Fools myself. Missing. 17.
time for a change.
Ano ba indot na knock-kiss na pang ito?
Ito.
Ano pa indot na knock-kiss?
There you are. Let's knock him down.
Bugay.
Jack, careful of the gas. You don't want to breathe too much in.
No way! Go to the light. They're open! We should be... Here! Out of my sight!
Pass this lava.
Looks like the lava's hardened.
Great. We can expand our search.
Come on!
Wonder what's in there.
That's weird. I'd expect it to be hot, but it's actually pretty nice.
That's because the fire crystal's covered in darkness. There must be a fiend here.
I'll bet. You look happy.
Keep it together! Looks like that hurts! This looks good.
Nice.
That solves that.
Reel it in, man.
Dark Cuiras.
More of those cubes.
Let's have a look.
Shira, oh shit.
Let's go.
Jack, let's go.
Away with you! Here.
I'm ready. Cut us up, Jack.
Lights out! Ha! Better tread carefully. It isn't over. I'm done with you!
Okay, tumuna.
Think it'll explode? Let's not take any chances.
Jack, don't let up. So nature made a cave back here. Interesting. Warm welcome.
Time to go to work.
We should be fine here.
I could keep going.
Ako, napatay na to sila oh. Na nasa lava.
Go to the light!
screwed that up.
Right.
On me, Ash. Crush you.
Ito kay mana pang kanong.
This.
Oh,
This one's got some teeth.
Think before you strike.
Ano gina siya?
ikaw, magkano daw protect.
I'm ready.
Ay, kulang ba dyan? Alam mo. Ah!
Up ahead. Come on, follow me.
Ah, agad.
It isn't over. Okay.
Time to fly.
Let's see what's inside. Here. I'm done with you.
Be careful. Something's on the other side of the lava, too.
Now then. Come on.
No sweat.
Barely even worth the trouble.
There you
Wala na yung kabayo.
go. Let's knock him down.
More of those.
Smash it.
Ano mo?
Nadiri po ito, nadiri.
Hindi na ako doon sa taas.
Right with you. Got you now.
Taka lang siya.
Ah, direct na may palayo din.
Move aside.
Pula lagi din.
Up ahead.
Time to go to work.
Balik siya.
Got you now. There you go.
I think we could use that.
Should we take a breather?
Nakuha na ko.
Ano ka ni short shorts? Pero na.
You ready?
Good job, Truman. That isa na
At least di na lang ni siya kon. Ano na Dark Giras. Level 50. Ang pantalon nga Dark Giras. Saka ganito, i-change pa naman ako sa yung ano. Ay, change pa naman sa ako.
Okay. Okay. Ito gain. Ash. So, asa man nadapit? Dark Giras.
Pantalon.
Mara to?
Hmm.
Ash.
Para improvement na nagkapantalon. Lain na.
Yeah, bites ako ah.
Mana?
Wait lang, sige. Para matagyan na dun. Nalaki sa Nina.
Kabuti mo.
Lagi ni sa Nina. Ang na dyan.
Mo to di kanya. Nakaset bagit siya.
Sa'yo na good diri sa mo. Wala sa diri kay wala ko sa Nina. Dark Giras ang good na kay Ash. Lang change.
Hindi lang ako bukay. Ha?
Safety equipment. Taka na good, wag ko say na diri.
Wag lang. Ano sa problema?
Ja. Oh, Dark Gira sa gulo na kay Ash diri. Sige daw. Nga na, Jude.
Alahi, gani mo ha.
Tsaka mo, Jude niya ko ah.
Ang pula?
Pula, Jude ako.
Pula gino.
Kasi mo, Jude, nasa Nina.
No.
Violet. Ito.
Dark Helm, gani na doon. Itong set as kuan ba ito, di ba?
Ang Ash ko din ako kay, ano na, Dark Giras
Pero muna nakaset.
Oo ka na, Dark Giras lang, tanaw tang taong na to. Hatagod sa kabali, tignan ko sa mga.
Check the bali.
Dati lang ako ano.
Cute.
Ayun siya. Na.
Baka ito juga pang mage.
Battle settings and conditioning na. Set as appearance again file. And then edit.
Anyong hasido. Buo na kukutot. Bawag nilungag na sagi.
Kaya, Atigdas ko ah.
Dahil lang. Kumano na naman yung kuhan. Hindi lagi.
I'll crush you!
Huh?
Out of my sight!
Dili, paano maghihatag sa ako? Ako pumangyapon ni.
Ha?
Ako pumangyapon si Ash. Sa kaya? Kumusta sa skodong niya?
Tulog na.
No,
Di, mo lakaw na siya. Moktas na.
Nakalakaw na siya mga kalima.
Ano to? Dulaan tayo ang ano? Katong construction.
Dulaan yan. Yan sa City Hardware.
So cute.
Paano yung
Naka-shorts lagi ko.
No, ano dyan ako?
Wala yung pantalon na mo.
No?
Ay, kung karakter.
Naka na dyan ko. Nana dyan, naka-short siya. Ito? Basta ako na po yung lain.
Body teams.
Bitaw, wala ko yung suot.
Wala jud.
Wala.
Kaya kasagaran na ay item na dili masuotan og pants. Ano
Hindi.
natin?
Pero na.
140, 140 is
Nakapantalon, di na siya og.
boring.
There you are. Let's knock him down. That looks worth picking up.
I'll take that.
Come on.
This looks good.
Nice. I'm ready. Go to the light. I'm done with you.
Mga buto niyo.
Go to the light.
Better tread carefully.
Pumatay. Nahulog ko sa lava. O ay ba lava?
Can't take much more.
Careful, Ash.
Away with you.
Lava.
We're a few steps behind.
Kailangan yung
We're in for it now.
Think before you strike.
kailangan hindi mo sila mapatay.
That solves that.
Reel it in, man.
Don't give up on me, Ash.
Ayun na, ayun. Hindi sayang yung point.
Uy.
Come on. There you go. Feel it.
Water ko.
Treasure, huh? Are those cubes?
Let's relax for a bit.
Itong block na.
Balik ka. Doon na.
Ready kids.
Boss na ba?
Boss na.
Yeah.
Guys.
Nga boss nila sa inyo na kayo.
Nakikita kong biskuit. Yan, ako isa-isa yung maya ba?
Sa mana?
Kanigot.
Libo.
Unang gireseta na tambal ni ambot who the fuck doctor is that? At taga-malita na friend ni Martin. Katungod sa kung pimple ba, nagdako gitsag taman niya. Kasi kanang sakit ko siya, naganana siya.
I was having such a splendid
Patanaw do kagaya if mo ba iyahang kung siya mag-recommend ka na ba na tambal or daily. Ana.
Mana?
A blood-drenched castle. Oh, how wonderful it was.
Marili.
But you woke me from my slumber. The power of fire is mine. I will
Taga-malita
reduce
yung
you
doktor.
all to ashes.
Malan.
Nagisan na ako sa mga. Dikit yung madungog kay sabakan dun.
May Cassiopeia mo din.
It's faster than I expected.
Gay.
It is.
Manalo.
We should keep our distance for now. Look for an opening, then strike.
Keep it together.
Antibiotic.
Here.
Ito. Ito ka madungugan niya. Kailangan. Kasaglawan na si Cassiopeia agad.
Watch out for the glint in her eyes. They'll stick you in place.
Nga na,
What's
ano
wrong?
dyan na stone.
Move.
We're in for it now.
Think before you strike.
There you go. No.
Kung may pagkatalo na ata.
You're not fooling anyone with that!
Time's up. Okay.
Bang.
Kanya mo sa associate. Guy.
Away with you. Pissing me off. Give us everything you've got. We'll always be a step ahead.
Kalayo na sa kasi.
You okay on potions?
No room for mistakes.
Alright.
Out of my sight.
Fire swords. I should have expected as much.
Be careful. Blocking those will leave a mark.
Guy.
Okay.
Oh.
Better tread carefully.
Nasa espada. What the fuck?
I'm ready. I'm not dead yet. My sight. Stop struggling already.
Ano dito? Far right.
Level up din akong job na swordsman lumas kung ako lang siya ginaan.
Don't worry. I got this.
Look. Oh.
Narapos lang buong koban.
Ouch.
Not good.
Not good. Pwede sila kong ghost diri. You will enter a store event from this point, living room and continue in solo play. You have left the room and begin offline solo play. Kung gusto sa mag-story na dito, nabawang na dyan.
There you are. You really should be careful of that mist. It could drag you into the past. Or worse, turn you into a monster.
Really? You don't say. Was a heads up too much to ask for?
And deny myself the joy of a kindred spirit?
So you're a monster?
In a manner of speaking, I suppose you could say I am. Have you ever seen things in Cornelia that just don't seem to belong? Things like this tower? Lufenia leaves its detritus in our world.
Who?
Lufenia, a mysterious nation that created our world with their advanced technology, then vanished.
Just vanished?
Yes, although if by choice, I cannot say. Now then, I believe you have some crystals to revive.
Main mission, Phantoms of the Past.
Mas lagi nakatagana ka ng mga rod. Main mission,
Ngayon mo
Phantom
ya?
of the Past.
Katay mo nga, ingon mo.
Mag-meet si
Kailan, nasilap, kailan. Next one si Marsamba. Kuan daw siya, yung bugas. Nga, hapit na mamunga. Ando. Nagnana to no, nana?
Nagnana siya, as in, grabe na siya, nibukol good siya.
Bukol daw. Mo na gi-respect sa iya, Linda Maisy.
Wala lagi license number, makapalit na siya.
Wala daw yung license number, makapalit ba daw ka ani? Wala ka.
Nakapalit man. Nakapalit siya. Si Mama, actually.
Kapalit yung mama. I-resitahan doon sa...
Amigo ni Martin.
Ang friend niya, may friend to taga Malita. I-resitahan siya. Man, inat... Muna siya. Kaya na. Kaya daw. Ina daw, ano si Manalo. Ano nga ba ito yung license number yung kwan? Ina nito niyo.
Ano kay ko? Malita lagi. Okay, ayos kay.
Oh, kailas siya. Picture daw ana siya.
Unsa ang?
Ang mong kuan kay basi daw magdala nag-blade.
Mandala og blade ang. Picturean nang unsa?
Imong tudlo.
Ha, wala ka sabot. I-picture na ako kung bugas.
Oh, picture yun.
Para madala ra og.
Kasi madala blade ba hiwaon lang.
Iyo, luod gani kay siya no kanang hugasan gano ko siya murag ni jelly. Tae kay.
Picture gani daw.
Isa na ko sa imo. Iyo.
Yaki. Bandera ka. Wala mo ka sa daan. Bandera ko sa di. Bandera mo halin ni. For sa kabulan ka upat ra mo. Upat ra gud ka. Tanong tag 2020 tos 2000 pila ini kan. 500.
Luod kay siya.
Times 2080. 30. Imong inadlaw sa imong tao rito. 26 days. Ha? Sirado yung clinic eh. Palista sila eh. Para appointment. Ano daw? Pero?
Good kay siya no?
Ano ni Chanak yung ano ni Chanak? Yun sa doon mo.
Wala ka balo. Ang una ato kay pimple siya nga sakit. Tong Thursday. Tapos Nakakita ko wipe. Ha?
Ano na yung flower?
Kuan, nakakita ko wipes. Ay nangayo ko wipes kati siya. Mo to kung gibutang kay kuan man siya kanang sakit kay siya pimple mga gamay. Mo to nida ko siya. Naingana siya.
Ano yung wipes? Kita ka pimple nga may tapos yung wipes. Pag wipes ni ang taro ng puti nasuko siya laka.
Kuan kanang wait lang, nakamit ko basta anti-inflammatory something.
Unsay pangalan?
Wait lang. Kuan ako.
What?
Kapis, charis.
Good piece. What's that niya?
Pinit ko yun. Oxide kalamay. Charis. No? Tapos kuya.
Ay, gano'n. Sa tokside kalamay daw. Sa to? Oh, yun sa to.
Pero kung isa sa yung
Oxide
calamine.
Oxide calamine. Zinc oxide.
Zinc plus oxide calamine.
Dili daw ni.
Unsa man?
Ay, open wound daw na. Dili na dapat.
Wala gina ko siya gibutang sa ano no, katong sugod pa lang kaysa kilid ra na ko siya gibutang.
Asa ang zinc ug calamine para daw sa mga rashes. Yung mga infected tam daw na so dili na siya pwede.
So sa ano kay butang, naka-suggest.
Sorry, butang kato lang. Ino na to niya. O ino na to nimo.
So di na ko butangan ni.
Ang imong pangtulak kay kwan. Kani daw clindamycin ang pantulak kay betadine.
Ako agbabindi.
10 days. 10 days na lang 10 days.
Okay, ako
10 days
sinada.
na ni.
10 days na lang.
Napalit na ni.
Unsa? Oh, napalit na ni mama.
Ano pagtulo. Pwede man niyo kanina lang gyapon ipadala.
Unsa day cause na naging ana siya? Wala ko sabot. Gi-wipes lang man ako siya good.
Basig. Ay ano daw. After 7 days murag walay kalambuan, straight na lang 10 days.
Sige.
6 hours, every 6 hours din eh.
O gani, 7 sa ana si katong doctor na whatever na nag-send na kay
6-6 doon, 6-6 doon.
6-6?
Hmm.
7-1.
7-1.
7 p.m. sa 1 a.m. tapos 7 a.m. tapos 1 p.m. ana.
Ah.
Oh, pwede rin.
6-6.
6-6 or 7-1. Pwede ra.
6-12-6, 6-7.
7 man ko nag-start kaganina. Okay ra?
7-1. Oh, kailan tayo mo sundon?
Oh, sige. Copy that. Wala ko duty.
Ah, ito ana.
Oo. Oh, kalinturahon mong ko. Buwang na jud. Tingnan ako si Omar siya pagpa-check up na. Saba, uy, charis.
Sabuni.
Mutuo mo kung kay. Mas gi-validate pag ako na kay sa katong gihatag ni Martin kay na. Kanang kon ba kanang kay ra jud kang mutuo.
Ako po sayara po ko kay. Makita mo na ko siya magtrabaho gud.
Kanang na ako trust issue sa doktor. Certain legit man na. Tapos ni ana tong taga pharmacy mupod gid ang imnon. Nga karon kay moto. Di man jud ko mo na, di ko ganahan magsamok-samok ba. Hindi na lang mga tanan na lang jud ko kay kuan. Ako trust issues. Bono.
Ako po na ko sukad kung kuan ganang mga ginastori ko dilab sa kuan ako trust issues sa mga doktor. Pero nakalimtan na bla bla.
Pwede gina ni mo siya mapalit nga ko ano. Si kuya. Hello, lol tayo. Wait lang.
Asa ang kwarto? Kailangan.
Hilo. Ask kuya.
Uno Roberti.
Music
Thank you for-
thank you. Samira.
Mana po ko ba? Ano ko yung mga trust issue sa kwan?
Kasi siya sa doktor.
Kaya ka na kung nang po siya mag-usay mga naglagot yung kunik kuan ba kay pag-check niya kay ang giik niya kay sakit lang daw ang tiyan gitagaan lang niya ginani pag-check na ako kay ning ko kayo ko dili naman kailangan oy edit sa ang niya pag-check na ako kay kinahanglan man di operahan oy kay sakit man dai ni kaayo manya ginapa ang ending kay namatay
Mamatay na siguro. Charis.
ang ending sa ko kinamatay ang katong pasyente kay wala na operahan
Kalain na nun.
gani mo rin natas issues
Trust issue sa doctors. Ito mo, tanan lang yung ko kay ka. May ganyan, sulod ka. Dili tanan doctor kay saving lives. Pero weird yung kay siya. Kay kon siya ba ang iyang pimple no kay gamay kayo nga pula kay siya nga gamay nga mura siya kanang normal gud na bugas. Pero sakit. Kanang ang nasya sa sulod kanang pag kapon nimo to siyang kanang sa kilid gud niya kay na siya unod. Sakit. Smooth to. Idako siya kay ibutang na siya wipes.
Basi. Ko na matagtiki.
Dili pod. Dili man daw yung papa. Dili po sa matagtiki, uy.
Nga matagtiki.
Makatakod ba, di ba?
Kuan man na siya. Ambot sa na kalimay ko sa nangakuan bakterya sila bunta na istorya na sa una.
Sa ilaga, charis. Matagtiki pero sa ilaga nako.
Iba rare lang makamatagtiki kay nagapamunas makagtarong.
Oo.
Nagapamunas, nagaligo, nagapunas tapos
bugas lagi siya. Kabalo ko nga bugas siya kay always ko na nga bugas ka ng sakit bito kayo pero isa lang kabo. Katulong gid siya na time nga ni dako gid tamod tungod sa wipe siguro kay alcohol sa wala ko sabot.
Basta sa wipes tapos kabalo biya ka mga bakterya kay kuan biya kay na sila sa tubig.
Mo
When there is water, there is life. Mo biya na ang term nila.
Moto. Pero nihiyos-hiyos na ni siya.
Nag-inom naman. Pero sa kalalas, first inom.
Kaganino? 6. Ay, 7.
Pero sakit siya?
Sakit siya like what?
Sakit niya ngul-ngul na ba?
Ang sakit siya.
Ako po, shingles.
Ano siya, no?
Karagong kuan, kung sa bata pa kay chickenpox. Kay isa raman ka chickenpox, di ba? Kada ko daw mo balik daw na.
Ay mo dako pag mo balik din na pag dako na ka.
Oh, pero dili siya kuan, ma-trigger siya ba, ma-trigger.
Pag singgas ka karon so makatakod ka pag paayuhay na.
Ayuhay na ni. Ay, ayuhay na jud ko. Ayo na jud ko. Last week ni nag-start.
Di ba diya man daw na matakod?
Magtakod siya kung dili ang German measles tong makatakod kung malaya. Ang shingles
dili siya sa chickenpox. Awin ako sa chickenpox.
Mo to niya.
Swiper, no? Chickenpox.
Lain medyo kay di ba ang chickenpox kay tibok lawas, naong, di ba na? Ang shingles kay lahi.
Okay.
Gikan sa ang nalay shingles na ko, gikan sa gikan sa lower panga na ko, left side. Lower, panaog sa tawa na, sa liog. Padulong sa tawa na, sa breast. Pero kutob lang sa tutoy. Left side na tanan. Guman. Kutob sa kanang naay kaning tawa na. Kanang injeksyonan banda nga sa baga. Kanay bakuna. O di ara pud kutob. Di ara pud siya kutob. Og sa likod. Di ara pud nga side.
Kana ka immunodeficiency pero dahil lang kutob sa kanang lawas sa part.
Ano sila siya? O di man kay iya mo tirahon sa imo kay ang imo magong sa nang kanang murag sensory nga nerves mga nerves maguna siya So kana siya ang gitira sa imo kana siya nga part. So kana siya mga sa tuig na C4 or C4 na siya. Sa C4 na siya nga nerve ko. Oh, ano din aday. Oh.
C4 na katumbong ba?
Wala C4 nerve. Oh, tama jud oh.
Oh, i-search ang C4. Bomba na ko.
Oh, tama jud C4 nga nerve. Ayun na. Oh, ano siya sir? Oh, muna siya. Oh. Mga C, oh, muna siya. Mga C daw nga mga nerves ang iyang ginatira. So mo ton ko una anap siya. Dili lagi nakuan. Oy, dili lagi nakuan na kanang murag kanang allergy ra na. Napatataw gyud siya. Sa left side lang gila na no. Ako, sa left tanan, pati sa likod, sa left lang.
Diba na tubig-tubig sa sulod? Yung chicken pox?
Oh, ana. Pero kani wala siya na kuan. Di siya ni samot nit. Ano siya nga, love, basig shingles na. Pagka second day ko, lain-lain akong lawas kay murag kuan. Murag kog, ang left side na ko nga taas kay murag kag kanang nagdarog ikan ba? Sakit. Murag pamaol. Pag nagpamaol, katol, ug mura og nagkarain. Murag hapdos ug nga murag napaso. Ana ko na feel. Chalo singles yun na. Dili ka magtapad tulog sa mua ha.
Bang. Goodbye.
7 days yun.
Since 7 days. Yung ko 10 days.
Ako ginom tambal eh. Kaya ana siya nga. Gusto ka magtambal, antiviral. Ko, sige, magtambal ta. Ada siya nga. Oh, tag 60 ang tablet. Pag man 3 times a day, pa. Sa 7 days.
Pero to na lang malaya.
Mawala raman na. Ano siya, antusan lang.
Usa na kasi kay doktor mo siya. Wala raman na siya.
Paguman, ito ko sa akong feeling sa natapad ng balay ba? Ay gagawin ako. Asa, lagi singles ko ka. Ako gi-singles ko dati. Kuha na. Nagpa-doktor jud ko tapos akong gasto dako kayo. Asa mga 7,000 to na gasto. Ano siya? Mga 7,000 ay ko ba. Ako jud kay hulatan ako mamatay. Ako kita gagtambol sa.
Kay mahal lang 3 times a day.
Hulat lang mamatay mo. Ano saan eh?
Yan, ano, yung bote ko.
Regular niya?
Regular. With fries. Mag-Israel ko ah. Pwede ka mag-karma ya. Karma meal.
Karma? Oo. Israel.
Kaya na ha, di ka mag-karma.
Daw gatap sa karma ko sa'yo arit. Si Mundag still.
Karma meal. Taonan kay niya ba? Kay wala pa to siya sakit pa kaya to siya nag-Starbucks kami ni Shai. Ako lain naman kaya akong lawas ay. Ako kaya lain naman akong lawas sumulit na. Ulit namin. Pagkagabi eh marag natarog siya tungod sa online. So siya ni agay gud marag kakarang giti siya ba? Sakit kayo. Pero wala siya ni buto, wala lang natarog lang siya. Pagkaugma, hubag na ka akong lips, nabuang na jud kanay. Tibuok na ko right na ano ko gibayo. Ano man ni bugas ra man unta ni. Tae na.
Claro manad. Ano, practice na pagbuhat og kuan og excited ako mag-lotion, buhat og lotion.
Lotion?
Eh, para partners akong sabon.
Kakuan ka na. Mura, isa ka pack na. Isa ka set.
Sure.
Pero normal ra na yung kalinturan ko sa ingani or daily.
Oo, eh, kuan naman ka. Anong infected naman ka. Kalinturan juga na. Kaya grabe naman. Naga-fight na imong lawas. Naman gusto na niya patyon yun niya. Pwede niya basta-basta mapatay. Gigamit na po ni mo ni akong kung ano, may gaya kabantay.
Wala ko naggamit eh.
Akong flash lagi, ubliktad.
Kamot lang. Wala ko nagamit karon mga pila ka days. Kato lang last.
Ay,
Katong
before,
pero
di ba na?
nakabaron tayo, makato.
Oh, wala. Pero di man, URF, beto no. Dili beto rank na eh. Normal.
Oo. Normal.
Di ba lahi ang punang normal? Bulok man yung lang kon. Mulahi ang runes. Mag-Arcane Comet ko? Iri lang.
Kasi ako sana, i-live lang ko. Go po kayo tao, AP tatanan. Buwang nito. Ay, ako rin ADD eh.
Akong bahala sa'yo. Pildi na yun.
Jin, Jay kalaban.
Patay, way makali kaya ni Ron.
Ano yung support?
Listen. Ito, kung nag-support listen, tapos na ako mag-listen support daw ko. Kaya di na tamanula.
Hindi na ko mag-listen eh. Yung listen kay Platinum.
So let's continue our discussion. Now we go and talk about
Wala pa silang Fiora.
Vasoconstrictor. So earlier,
Iron.
we already had a
Yung
preview
mo din
of
itong
your
pa-shield
Vasoconstrictor. So this is one of the components of your anesthetic carpule. And we said there are two main reasons why we need to incorporate vasoconstrictors. The first one being to prolong the duration of your local anesthetic. So how does it prolong the duration of your local anesthesia? By preventing the systemic absorption of the local anesthetic drugs. So by preventing the systemic absorption of the local anesthetic drugs, the anesthetic drugs are kept in contact with the nerve fibers for a longer period of time. So there is prolonged duration of anesthesia.
Naku, imagine ng mga
It also
doktor
decreases the likelihood of
sila makita na hapit na mamatay.
because it allows
Maluwi
smaller
ka sila.
volumes of the anesthetic or of the anesthesia to be used.
Or ka na murag.
Without a vasoconstrictor, there will be higher plasma levels of the local anesthetic drug, which may lead to toxicity. And then lastly, the minor significance of your vasoconstrictors would be to provide hemostatic effect. So, please remember that the hemostatic effect of your vasoconstrictors will only be effective on smaller blood vessels, mainly the capillaries. So, if you perform a deep injection technique like your inferior alveolar nerve block technique, you don't expect any hemostasis during surgery. So, for you to have that hemostatic effect, you need to do local infiltration on the areas where you will create your incision. Because again, it will only affect the superficial capillaries, the very small blood vessels, and that will provide you the hemostatic effect. So your vasoconstrictors are known to be sympathomimetic amines. So when you say sympathomimetic amines, their effects are similar to that of the sympathetic agonists. So these are the things that they can add in your body. Of course, it can produce vasoconstriction, bronchodilation, dilation of pupils or the mydriasis effect. It can also induce sweating and positive inotropy and chronotropy on cardiac muscles. So when you say positive inotropy, you increase the force of contraction of the cardiac muscles. When you say positive chronotropy, you increase the rate of contraction of the cardiac muscles. So there are three known groups of vasoconstrictors. First would be the pyrocathetic derivatives. So your epinephrine and your norepinephrine will fall under this category. You also have your benzol derivative. An example is your levonorepinephrine. And your phenol derivative, under which is your phenylephrine. So this is the mode of action of your vasoconstrictor. So remember that all the vasoconstrictors that we mentioned earlier, they are known to be direct-acting agents. When you say direct-acting agents, they directly attach to your adrenergic receptors. So when you say indirect-acting agent, they only provoke the release of your epinephrine and your norepinephrine. So these adrenergic receptors are divided into alpha and beta. So depending on which receptors you stimulate, the effects will be different. So the alpha and the beta receptors, they have opposite effects. The alpha receptor stimulation will result in vasoconstriction, while in general, the beta adrenergic receptor stimulation will result in vasodilation.
Kumahatag og libre.
So specifically, your
Oh my
beta
God.
receptors, there are two kinds, the beta 1 and the beta 2. The beta 1 receptors are found in the heart and in the small intestine, and when they are stimulated,
Kumahatag og libre
it
sa
will
inyo.
result in increase in heart rate, increase in the force of
Nag-ambak ka para
contraction
kung
of the heart,
karakter.
and even lipolysis, because again, they're found in the small
Ano na
intestine
ni mo
as well.
Lah!
While the
Oo
beta
nga.
2 receptors are found in the bronchi and the vascular beds, the stimulation of which will result in bronchodilation and vasodilation.
Ako dili ko kalas.
So, just some of the things that you need to remember, your norepinephrine stimulates both the alpha and the beta receptors, but the alpha effects predominate, with little or no effects in the bronchi. While your epinephrine is a powerful stimulant of both the alpha and the beta receptors. So in higher doses, the alpha effects predominate, while in lower doses of epinephrine, the beta effects predominate. Please remember this because these concepts will come out later during our discussion. So let's start with epinephrine. The known brand name is adrenaline. These are the known concentrations, but of course the most popular would be 1 is to 100,000. If you desire hemostasis, then you need to use a more concentrated version.
Imagine na ko na operahan ko ni.
Okay? But if you don't really need hemostasis, you can stick with the 1 is to 100,000. For a more diluted form, you can use these two formulations. So what are the effects of epinephrine in the cardiovascular system? So since it stimulates your beta 1 receptors, it will have a positive inotropic and chronotropic effect on the heart. So increases the cardiac output and the heart rate of the patient, and it may also induce irritability of the myocardium. So when you irritate the myocardium, it may produce premature ventricular contractions and even tachycardia. Alpha receptor stimulation in the cardiovascular system will result in vasoconstriction, therefore elevation of blood pressure. While beta 2 receptor stimulation in the cardiovascular system, specifically in the blood vessels, will result in vasodilation. Hence, when you're using epinephrine, after increase in blood pressure, there is a slight fall in the diastolic pressure, especially in lower doses. In the respiratory system, the primary effect of epinephrine is bronchodilation. In the central nervous system, when you reach the toxic levels of your epinephrine, it will produce alerting effects such as jitteriness, apprehension, and mild excitation.
Paranoia.
Miscellaneous effects or other effects of your epinephrine, it can also increase the blood sugar level because epinephrine is known to be a hyperglycemic hormone because it opposes the effect of
nagisi ang tendon si Martin.
And it also increases the glycogenolysis in the liver or the breakdown of the glycogen in the liver and the muscles. And of course, mydriasis.
Sa gym niya ba?
Because this is a sympatomimetic apat.
Saan tawag ng atendo na
The dosage for epinephrine is 0.2 mg. This is the safe, safe arbitrary maximum
kita siya
dose
video
for
sa
healthy
akong yun.
patients.
Namo ko sa friend
While
na
for
dato
patients with heart conditions or cardiovascular problems such as coronary artery disease, myocardial
surgeon man to.
you have to
limit
the
na
use
siya
of
murag
epinephrine
surgical something.
for up to 0.04
Dito siya gi-opera sa balay sa doktor ya.
So this is important.
Nya nagsigarilyo ra gago.
For the maximum
Ano
amount
ko
of
yung gago
that you can use to your patients. So when do you need to compute for epinephrine? So you need to compute for the epinephrine if a patient poses with a significant cardiovascular risk. So if your patient is healthy, no need to compute for the epinephrine. You can compute for the maximum local anesthesia instead, which we will talk about later. Important as well in epinephrine is its known rebound activity. So what is rebound activity? Remember, if you're using epinephrine, it can stimulate both the alpha and the beta receptors. And alpha and beta receptors have opposite effects. Alpha receptor stimulation causes vasoconstriction, while beta receptor stimulation causes vasodilation. So in sufficient concentration or in higher concentration, the alpha effects will predominate. So you will observe vasoconstriction. However, when the concentration becomes very low, used during the biotransformation and metabolism of epinephrine, what will happen to the dose? The dose will become lowered. So once the dose is lowered, what will happen? The beta effects will predominate. So the beta receptor stimulation predominates, resulting in vasodilation. So the rebound activity is the vasodilation that you observe following the use of your epinephrine. So what will happen when there's vasodilation? There is unusual increase in bleeding. So there is excessive bleeding after. And this rebound activity usually happens at about 6 hours after the administration of epinephrine. So you have to warn your patients when you're using epinephrine. So after about 6 hours, there may be some increase in bleeding that he or she may observe.
And shoot fire!
This is how you compute for it. So remember, your vasoconstrictors are very diluted. So 1 is to 100,000, meaning you have 1 gram of epinephrine for every 100,000 ml of solution. That's how diluted your epinephrine is. So meaning to say you have about 0.01 milligram only of epinephrine per ml. So in a carpule, usually it's about 1.8 ml in volume. So you just need to multiply. So that means you have about 0.018 milligram of epinephrine per carpule of anesthesia that contains 1.8 ml of solution. So knowing that, you have that the maximum amount of epinephrine that you can give in a healthy patient is about 0.2 milligrams. So by virtue of division, you can give up to 20 ml of an anesthetic solution containing 1 is to 100,000 of epinephrine. Or that's about 11 carpules. So if you want to compute for the 0.04 milligrams for patients with cardiovascular problems, you just need to replace this with 0.04 milligrams. So 0.04 milligrams divided by 0.01 milligrams milligram per ml. Usually it's about 4 ml. About 4 ml of solution, or only about 2 carpules of anesthetic solution with 1 is to 100,000 of epinephrine can be given to a patient with cardiovascular problem.
Kay puros mga AP good.
Sorry po, paulit po ang inotropy. Inotropy is increase in the rate of contraction. In the force of contraction. So the heart will pump harder. While chronotropy is the increase in heart rate or the rate of contraction. So the heart will beat faster. So that's inotropy and chronotropy.
Tanga.
Let's review this question. So epinephrine is contraindicated in asthmatic patients because epinephrine exerts a beta adrenergic effect on bronchial smooth muscle. This is an example of a true or false question in the form of a multiple choice type of example. So basically you're given 2 statements. Then you need to identify whether the 2 statements are true or one of the statements is false or both are false. So let's analyze. First statement is epinephrine is contraindicated in asthmatic patients. That is not correct. That is false. Because remember, your epinephrine can produce bronchodilation. So knowing that, it's not contraindicated in asthmatic patients. As a matter of fact, when your patient is having a severe asthmatic attack, what you can give is your epinephrine. So the next statement is epinephrine exerts a beta adrenergic effect on the bronchial smooth muscle. That is a true statement. Remember, your epinephrine is a powerful stimulant of both the alpha and the beta receptors. So the answer here is the statement is not correct. The first statement is not correct, but the reason is an accurate statement. There's a question here. 11 carpules maximum for normal patients without cardiovascular problem. Yes, according to the computation, if you're using 1 is to 100,000 of epinephrine, you can give up to 11 carpules of that to a normal patient or a healthy patient. But again, please remember, if it's a healthy patient, what you don't really need to compute for the epinephrine. What you need to compute for would be the local anesthesia. the maximum amount of local anesthesia that we can give. Which we will discuss later. So next question. Following administration of 1% lidocaine, the patient feels faint and lightheaded and begins to wheeze. The injection of 0.5 cc of 1:1000 epinephrine subcutaneously will produce all of the following, except, so as you can see on the signs and symptoms of the patient, most likely the patient is undergoing an allergic reaction. So these are signs and symptoms of allergic reaction. So for allergic reaction, you can give your epinephrine as an emergency medication. If you're watching medical dramas like Grey's Anatomy, like that, they have what you call EpiPen, diba? EpiPen is an epinephrine that you can give to a patient having severe allergic reaction. So the question here is, which of the following is not an effect of epinephrine? Sedation, bronchodilation, cardiac acceleration, increased in systolic blood pressure, or none of the above. So epinephrine, being a sympathomimetic amine that can stimulate both the alpha and the beta adrenergic receptors, will cause all of the following except sedation. So epinephrine is not a sedative. Okay?
Training is the pinnacle of modern dragonology.
So next vasoconstrictor is norepinephrine. Brand name is Levophed. This is the concentration, usual concentration. This one is less potent than epinephrine, so the adverse effects are usually less severe. And for that reason, it is present in a more concentrated formula. Again, like what we mentioned earlier, the alpha effects predominate. Actually, the beta effects are negligible when using norepinephrine. Hence, when it comes to the respiratory system, we don't expect any bronchodilation. So for patient having an allergic reaction, you can give epinephrine but not norepinephrine because it doesn't have an effect on your beta receptors. So for this one, very important that you know that it can cause what you call a local ischemic effect. So what is local ischemic effect? So when you inject your anesthesia containing norepinephrine, it can induce tissue necrosis and sloughing, such as this one. So this one, there is tissue necrosis and sloughing of the palatal tissues following the injection of anesthesia containing norepinephrine. So why does it have a local ischemic effect? Because of intense vasoconstriction that is not balanced out by the vasodilation provided by beta stimulation, which is present in epinephrine. So in norepinephrine, you only have vasoconstriction, intense vasoconstriction, no vasodilation. That's why ischemia may happen. So as a general rule, you don't have, you should not deposit more than 4 ml of a solution containing norepinephrine into one area because again of its local ischemic effect. So if you will use anesthesia containing norepinephrine, make sure that when you deposit it inside the tissues, it should not be more than 4 ml. This is the dosage. So for healthy patients, you can give up to 0.34 milligrams of norepinephrine. But for patients with cardiovascular problems, you can give up to 0.14 only. So let's analyze this question. Norepinephrine is an unlikely substitute for epinephrine in treating severe allergic reactions because it is ineffective in improving blood pressure, ineffective in relaxing bronchial smooth muscle, dilates the pulmonary arterioles, or all of the above. So this one, norepinephrine again is not a good substitute for epinephrine in allergic reactions because it cannot relax your bronchial smooth muscles. So letter A is wrong because norepinephrine being a vasoconstrictor that can stimulate your alpha receptors, it can still improve the patient's blood pressure. Okay? But it cannot relax your bronchial smooth muscle because it doesn't have an effect on your beta receptors. Next is your levonorepinephrine. Brand name is neocubifrine. This one is less potent than your epi and your norepinephrine, hence it is present in a more concentrated formula. This one, similar with your norepinephrine, it acts directly and almost exclusively only on alpha receptors. And it can only produce up to arteriolar constriction. The dosage is about 1 milligram for healthy and healthy without systemic diseases patients, and up to 0.4 milligrams if the patient has cardiac conditions. Next is your phenylephrine. So this one is the least potent among the 4 vasoconstrictors that we talked so far. So for this one, this is considered to be the most stable among the 4. That's why it has longer lasting effects. So it is also considered to be the weakest, hence it has the least adverse reactions, at least severe adverse effects. And similar with norepinephrine and levonorepinephrine, this one almost exclusively affects or stimulates the alpha receptors only. Dosage is about 4 milligrams for healthy patients and about 1.6 milligram for patients with cardiac problems. I'm not sure if you're already familiar with felipressin. This one is not present in the textbook of Monheim, but was mentioned in the textbook of Malamed. So the brand name is octapressin. This one is used in dilution of about 0.03 international units per ml with 3% prilocaine. This one is being used in Japan and Germany, but this is not available in the North America. This is a synthetic analog of the antidiuretic hormone, vasopressin, and this is a non-sympathomimetic amide. So, unlike the first 4 that we talked about, this is not a sympathomimetic amide. It acts as a direct stimulant of your vascular smooth muscle, and the action is more pronounced on the venous microcirculation. What is good about felipressin is that you can safely administer this on patients with hyperthyroidism, patients taking MAO inhibitors or tricyclic antidepressants. So, usually these patients, they cannot receive your usual epinephrine. They are contraindicated with the use of epinephrine. So, for them, we can use your felipressin. But you cannot use them in pregnant patients because your felipressin, being a synthetic analog of vasopressin, it has both antidiuretic and oxytocic action. What do you mean by oxytocic action? It can stimulate the contraction of your uterus. So for pregnant patients, you cannot give your felipressin. And it is also not recommended when you need hemostasis or when you desire for hemostasis, because its predominant effect on the venous is on the venous circulation rather than on the arterial circulation. So if you need vasoconstriction, you cannot use felipressin. It will affect the veins but not the arteries. The dosage is, the maximum dosage is about 0.27 international units for patients with clinically significant cardiovascular impairment. So about 9 ml of this. Now let's talk about the termination of action of these vasoconstrictors. There are 4 mechanisms by which we terminate the action. First would be reuptake and restorage. This is the most popular termination of action for epinephrine and norepinephrine because they are naturally occurring substances in your body. Next would be the activation by the extraneuronal enzymes, specifically the catechol-O-methyl transferase. They can also be uptaken by the bloodstream, hence it can be filtered by the liver and then the kidneys, and then you can excrete them. Or through intraneuronal enzymatic destruction, specifically by the monoamine oxidase. So why is it important for us to know the termination of action? Because it will affect the potential drug interactions of your vasoconstrictors. So if your patient is taking tricyclic antidepressants like your clozapine, usually given for the treatment of schizophrenia, other psychotic episodes, and even MAO inhibitors. So MAO inhibitors are given for patients with resistant hypertension and for various states of mental depression. Both of these drugs will prolong and enhance the effects of your epinephrine and norepinephrine by preventing the reuptake and restorage. So by preventing the reuptake and restorage of epinephrine and norepinephrine, you will have prolonged and enhanced effects of these vasoconstrictors. Other potential drug interactions, if your patient is taking alpha blocker. So an alpha blocker, so there are several alpha blockers. There are selective alpha blockers, there are non-selective alpha blockers. But mainly, these are used either for hypertension, especially those that end at ocene, doxazosin, prazosin. Those are selective alpha blockers that are known for the treatment of hypertension. While these, thiazine, phentolamine, these are non-selective alpha blockers. Phenothiazine is used as a psychosedative, while phentolamine can be used for patients with pheochromocytes. So if your patient is taking alpha blockers for whatever reason, you will experience epinephrine reversal effect. So when you say epinephrine reversal effect, with the vasoconstriction, you will only have vasodilation because the alpha receptors are blocked. And then, lastly, when your patient is taking beta blocker, such as your propranolol, again, a treatment for hypertension, you will observe opposite effects of your alpha blockers. You will have vasoconstriction, definitely, but no beta stimulation.
Focus.
So in the selection of vasoconstriction, it should be based on the following parameters. First would be the duration of the desired effect. So how would you determine the duration of the desired effect? The length of the dental procedure must be considered. So remember, the duration must be long enough to complete your dental procedure, but not too long because it will cause discomfort on your patients. So take a look at this one. I got this table from Malamed. So just compare lidocaine without vasoconstrictor. You can only have up to 5 to 10 minutes of anesthesia when using infiltration, or up to about 10 to 20 minutes when used for nerve block. But if you incorporate epinephrine, regardless of how much epinephrine you incorporate, you expect up to 1 hour of anesthesia in infiltration, or even more when using nerve block. So that shows you that your epinephrine can actually extend or can actually prolong the duration of your local anesthesia. Another parameter that should be considered, of course, would be the physical condition of the patient. Because if your patient has any of these, thyrotoxicosis or hyperthyroidism, cardiovascular conditions, or even diabetes mellitus, all of these may contraindicate the use of your vasoconstrictors. Not an absolute contraindication, meaning it doesn't mean that you cannot totally use your vasoconstrictors in these patients, but it will be limited.
Are you smaller than before?
So another would be desire to produce hemostasis. Remember that your vasoconstrictor only affects the microcirculation, so you only achieve local hemostasis, and you need to do infiltration if you want hemostasis. And again, don't forget the rebound activity. You have to explain that to your patients. And if your patient is taking any concurrent medications, you have to be aware of potential drug interactions, like what we discussed earlier. And during general anesthesia, of course, you will be using your anesthetic gases like halothane, isoflurane, your fluranes in general. Remember that minimum dosage of epinephrine is recommended when you're using halogenated anesthetic gases. Because when you use epinephrine together with these anesthetic gases, they can sensitize your myocardium. So what will happen? Ventricular dysrhythmia can happen if you use epinephrine together with these anesthetic gases. So keep them up. So let's analyze this question. Epinephrine
Sure.
administration is contraindicated
Baba.
when halogenated hydrocarbon general anesthetics are used because halogenated hydrocarbons sensitize the heart to the arrhythmic effects of your epinephrine. So this is again a true or false type of question. So based on our discussion earlier, we said that epinephrine can actually sensitize the heart to ventricular dysrhythmia when used with your halogenated gases. So for this one, both the statement and the reason are correct and related. Next is the use of vasoconstrictors with local anesthetics is contraindicated in the following patients except patient with angina, patient who is hypertensive, patient who has had rheumatic fever, who has myocardial infarction, or patient with Parkinson therapy who is on levodopa therapy. So basically, we're being asked who among the patients can receive vasoconstrictors. So again, it's not an absolute contraindication, but we try to avoid vasoconstrictors as much as possible for patients with cardiovascular conditions. So the answer here is letter B.
Di ba ako pili pat yun ng kwan? Pili kwarta na kung
Levodopa
mo
therapy is a dopamine replacement agent for the treatment of Parkinson's. This is levodopa is a precursor to your dopamine. And dopamine is chemically similar to your epinephrine and your norepinephrine. So patient can safely receive your vasoconstrictors even if the patient is on levodopa therapy.
Kato pag maingatan na tod kamay ng value sa.
Do you have any questions before we discuss your local anesthetic solution? Are we still good? Are we still here?
Has been destroyed.
Chati kog mag-earth na mo, kapuyan kog ranks karon. Kapuyan makapirmi.
Kisa si Jetro.
I'm torn if I will be giving you your last break already. Since 8:15. Maybe let's finish the local anesthetic solution before we take our last 10-minute break.
Oh,
so local anesthetic solution, we know that the general definition of local anesthesia is the temporary interruption of all sensations over a specific area of the anatomy without loss of consciousness. And this is achieved with the synthetic compounds with a modification of cocaine molecule. Hence, the suffix is cane. Kasi ang parent molecule nila is cocaine. There are two groups of local anesthetics that you need to remember. Both of them contain an aromatic lipophilic part, an intermediate chain, and a secondary or a tertiary amino group, which is the hydrophilic component. So as early as now, please remember that your anesthetics contain a lipophilic component and a hydrophilic component. They only differ with the intermediate chain. So the ester group has an ester linkage, while the amide group has an amide linkage. Let's review first this question. Which local anesthetic has no place in the routine practice of dentistry? Is it your articaine, cocaine, lidocaine, bupivacaine, or prilocaine?
Training is the pinnacle of modern dragonology.
So, no place in the routine practice of dentistry. We're not using your cocaine because of the risk of abuse. So again, the two groups. The first one is the ester group. The primary drug here is procaine, and this is being metabolized by your plasma pseudocholinesterase. While your amide group, the primary drug here is lidocaine, is being metabolized by your liver enzymes, the hepatic microsomal enzyme system. So, agent of choice for anesthetizing patients without plasma cholinesterase enzyme.
Excellent.
So ito, baka hindi kayo familiar. Maybe you're not familiar with the other anesthetic drugs here because these are brand names specifically mentioned by Monheim. So in other words, these are brand names. These are the older brand names. So Pontocaine is a brand of Tetracaine, while Ravocaine is a brand of Propoxycaine. So knowing that, if your patient doesn't have plasmacholinesterase enzyme, what can you give? You can give your amides, specifically your prilocaine, because patients without plasmacholinesterase cannot metabolize your esters. These are the ester type of local anesthetics that are common, while these are the amide type. So, as a general rule, not a general rule, but as a tip to be able to identify amide types, they say you count the number of I. This does not apply to brand names, okay? It only applies to the generic names of the drugs. So, if you have 2 letter I, that's an amide. But if you only have 1 letter I, it's an ester.
Try not to get toasted.
So let's analyze this question. A patient allergic to carbocaine should not be given which of the following drugs as an anesthetic. So we all know that your anesthetic drugs or drugs in general, they display cross allergenicity. So if you're allergic to one specific drug, most likely you're allergic to all of the drugs under that umbrella or under that classification. So if your patient is allergic to carbocaine, carbocaine is a brand name for mepivacaine. So which of the following should not be given? Marcaine, Novocaine, or Ravocaine. So again, very important that you know the generic name. So carbocaine is mepivacaine. Marcaine is carbocaine is mepivacaine. Marcaine is bupivacaine. Novocaine is procaine. Pontocaine is tetracaine. While Ravocaine is propoxycaine. I will repeat. Okay, carbocaine is mepivacaine. Marcaine is bupivacaine.
Easy do kaya no?
Novocaine is procaine. Pontocaine is tetracaine. Ravocaine is propoxycaine. So if your patient is allergic to carbocaine or mepivacaine, which is an amide, then you should not give another amide. So which is another amide here? Your Marcaine or your bupivacaine. So again, if a patient is allergic to ester, do not give all of the esters. If your patient is allergic to an amide, do not give any of the amides because of cross-allergenicity. So let's discuss ester type of local anesthetics, starting with your procaine. This one produces the greatest vasodilation, hence it also produces increased bleeding episodes. Procaine has a very slow clinical onset of anesthesia because of its high pKa. Later, we will be talking about the pKa of your anesthetic drugs. But for now, please remember that your procaine has a very high pKa. That's why it has a very slow clinical onset of anesthesia. Hence, they tried to combine procaine with propoxycaine. Propoxycaine, on the other hand, is not available alone because of its toxicity. Metabolism is both in the plasma and the liver, and this is the usual concentration as well as the maximum recommended dose. So if you're planning to use this combination, okay, please remember that this is the maximum recommended dose. Local anesthetic agent with the shortest duration of action is Novocaine, again, is procaine, propoxycaine, lidocaine, or nesacaine. Nesacaine is a chloroprocaine that is used for epidural anesthesia, not really for dentistry. So with the shortest duration of action, it is your procaine because again, it causes the greatest vasodilation among all the anesthetic drugs. So because it causes vasodilation, what will happen? It will go to the systemic circulation, it will be absorbed by the systemic circulation, resulting in a shorter duration of action. So now let's discuss your amides, starting with your lidocaine. This is the most widely used anesthetic and is considered to be the gold standard. In terms of potency and toxicity, this is double the potency and toxicity of Procaine. So the baseline is Procaine. This one has more rapid onset of anesthesia, more profound and of longer duration. That's why it has replaced your esters or your Procaine in the market. This is the usual concentration, and this is the maximum recommended dose according to Malamed. Here I would just like to reiterate that regardless of the vasoconstrictor that you incorporate with your 2% lidocaine, you will achieve basically the same duration of action. So the only difference would be you have more hemostasis here compared to 1:100,000. Okay? Do not be confused, because in your older reviewers, they said that the maximum recommended dose for lidocaine is 4.4 milligram per kilogram. So, Doc, anong susundin namin? What are we going to follow during the board exam? I recommend that you follow the older references or the older reviewers, because most likely they are the references being used for the board exams. What about in practice? Why am I incorporating this one, the newer guidelines? Because of course you will also be using this in your practice. So in your practice, you can now use the 7 milligram per kilogram, which is the newer recommendation, with an absolute maximum dose